All right, it is May 24th, Monday, and we're in PTA200, which is kines, and we are now recording. So today we're going to talk about posture and postural assessment. And today's postural assessment lesson is going to be a combination of both going over postural assessment and you guys kind of working with me on postural assessment as more of a group comp, because there is a postural assessment comp that goes along with this. Normally, what I would do for the postural assessment comp is I would have you guys come in and I had set up the Alinabod in a class, and I take a snap picture of all of you guys from all four angles, and then you take it home and you assess your own posture for me, which everyone always loved. It made them feel so good about their posture and their body mechanics and all that fun stuff, and never caused any tears ever. But we're not going to do that this year. What we're going to do is we're going to look at some other people's postures so we can point fingers and laugh at them. No, I'm just kidding. We're going to look at some other people's postures from the Alinabod website, as well as some that I found on the internet along with postural assessment, just some that have some really bad posture so we can work on them together and talk about what are we seeing when we look at that posture? You know, what's going on with this patient? Why do you think we are going to, as PTAs, look at posture? What do you think the reason for looking at posture is? Anyone have an idea?
Where someone may be weak.
What was that? I'm sorry.
Like where someone may be weak, like their muscles or hips.
Right, looking to see if there's any type of muscle imbalance we can see, right? What's the number one reason people come into PT? What are they complaining about?
Pain.
Pain. Right? And you'll be amazed at how much pain is just in posture, right? Because we're all like this nowadays, right? My precious, my birthday present, right? We're all in our phones constantly, right? Just if you ever want to take a look at posture, and this is something I highly recommend, just make sure you wear a mask when you do it. Go downtown, especially on a night when they're doing, it does affect everything you do, right? Even the way you digest. Yeah, exactly. Even the way you breathe. But go downtown on a night that there's a hockey game once. And what I highly recommend is that bridge that crosses over to the T-Mobile Arena, stand on that bridge for a while and watch people. It really is telling to watch the people's posture as they go back and forth. And now that you guys are starting to get into the thick of things here with the PTA program, you're going to start noticing this. I remember when I was way back when I was in when I started my PTA program, I didn't think it was, it's not this. She's telling me that my instructor's telling me you're going to start noticing things about people's bodies. No, it's not going to happen. I went on vacation in Jamaica for a week, and I was down there and I was at this really nice resort and like laying out by the pool, enjoying some rays. It was one of our breaks. And the sad part is the only thing I could see as I'm looking around the pool is bad posture, not fit correctly assisted devices. I was seeing people's scars like on their backs or their legs or their knees. And I'm going, I wonder what surgery they were having or what surgery they had. And that was that moment that I realized I was broken. And then forever since, I have been broken. You just notice these things now. And it's really hard to walk through a casino or walk downtown and see the people walking with their walkers the wrong height or with really bad posture and not correct them, not want to correct them, right? When it comes to postural assessment, the PT is going to do the initial assessment, right? They're going to say that this patient may need a postural assessment. Now, we may take the pictures, we may even draw the lines and kind of see what we're looking at. The PT is going to take that assessment that we give them and write a plan of care for the patient, right? Even with evaluations, when we talk about this, because we're going to talk about it when we do manual muscle testing and goniometry, even when we do that, we may do all of those numbers for the PT during the evaluation. They may call us in and say, hey, I've got to go do mobilizations on your patient. Can you get me the goniometry and the manual muscle test on the patient's shoulder? We can do that. We're not making an assessment of the patient at that point as PTAs. We're just going in and going, oh, well, they have this range of motion and they have this manual muscle test. And the PT is going to take that and interpret that and design a plan of care off of it. Same idea here with posture. So some terms we need to understand. Forward head. Forward head is exactly like it sounds, right? We talked briefly about it, right? Our head should kind of be in a neutral position with our ears over our acromion process, but we kind of sit like this, don't we? And we get that Cro-Magnon posture, as I call it, from the old Cro-Magnon man that we see pictures of in Gigantothis and all those other precursors to humanity. They all had this posture here. And there's some, hereditary reasons for that and some genetic reasons for that, but we develop more of an upright posture, right? That's part of the reason, if you look at some of the history of anthropology, that says that's one of the reasons why we might have developed into the dominant species, on top of the fact that we learn to not only hunter and gather, but to gather in groups. The forward head, right? If I have forward head, all these muscles in the back of my neck, what's happening to them? If I have my head way forward like this, what's happening to all these spinal muscles back here?
They're straining.
Yeah, they're straining, they're stretching, right? And so what we're going to find really quick, and not only with posture, but throughout the semester, is when muscles tend to get stretched for long periods of time, they get what's called stretch weak. Right? And you can think about this. I found an old hair tie here, right? You can think about this like a hair tie, right? This hair tie, as it is right now, it's brand new. It's got some nice elasticity to it. It returns to its original shape, right? You can make little twisties out of it. But over time, as this gets used, what's going to happen to it? Those of you that have long hair.
You stretch it out.
You'll stretch it out, right? It's going to get stretched out, and then it's not going to be nice. And eventually you're just going to toss it because it gets annoying. Or you'll find it on the road somewhere because it fell out of your hair, or whatever, it's tied into your ear, I don't know. Same thing happens to muscles. As those muscles continually stay stretched like that, they eventually become weak. And they lose the ability to not only return to its original shape, but to even contract. And so they lose elasticity, but they also lose tension. While those muscles in the back of my neck are getting really stretched out, the muscles up here in the front of my neck are shortening. Right? And instead of becoming so loose, they're now becoming tight. And I'm getting this kind of posture here, right? And now my neck, my platysma is a little messed up. My SCMs are all messed up. My anterior and middle scalenes are messed up. They're going to compress down. And what comes out, if you remember from anatomy, what comes out between the anterior and middle scalene? Anyone remember that from anatomy? Pretty important structure comes out of there. Nerves, right? Which specific bundle of nerves?
Brachial plexus.
The brachial plexus, exactly. Right, that's where the brachial plexus kind of pops out and then goes out to the arm. We also have a lot of blood vessels that come out through there. It's called a scalene triangle, right in between middle and anterior delt. And so now if they're tight and they start squeezing down, just from forward head, what might the patient start experiencing in their hands?
Loss of feeling?
Yeah, loss of feeling, tingling. Oh my God, my fingers are burning, right? Or if it's compressing on the blood vessels, what do the fingertips feel like?
Numb.
Yeah, numb and cold, right? Every time I'm sitting watching TV at night, my fingers get cold. Right? Well, what do you look like when you're watching TV? I look like this, right? Oh. Or every time I sit down to play video games on my computer, I lose feeling in my left hand. Right? Forward head caused that. Usually what goes along with forward head is rounded shoulders. Now you can have forward rounded and posteriorly or anteriorly and posteriorly rounded shoulders. It is really rare to see somebody walk around like a peacock. That's kind of what I call this posture here, where their shoulders are rotated backwards. But forward rolled shoulders or forward rotated shoulders is really common, right? I think of this as kind of the bro pose, right? Those guys that are at the gym, yo, what's going on, right? You get those forward rolled shoulders. Now, not only is your head and all those upper neck muscles stretched out, But now all those broad muscles across the middle upper back are stretched out. And once those get stretched, ooh, now we start developing trigger points and start developing pain back there. Right? And we tell the patient, okay, let's try stretching that. And you tell them, okay, reach back with your arms, like, oh, that hurts. That hurts so bad. Because they're just so used to this posture, right? And the other thing that goes along with this is internal rotation of the arms. So think about it. When you're in the anatomic position, right? Your hands are supposed to be out like this. But as those shoulders roll forward, the hands rotate inward. And so you end up with people with their thumbs in against their hips versus just neutral down at their sides, sort of at attention position you think of from the military. So as that happens, the shoulders and the rotator cuff gets kind of torn up. So you can see how just the top portion of their body now has messed up a ton of stuff. Also, if my shoulders roll forward like this, my rib cage is compressed. My rib cage is compressed. I can't breathe in as deep and as, exhale as much. So that leads to problems. Kyphosis and lordosis are terms that kind of tie together, right? So when we're talking about a kyphosis, if we have anterior here and posterior here, right? What is a kyphotic curve is going to look like this. It's going to look like a posterior hump versus a lordotic curve looks like that, right? It's going to be an anterior kind of hump, if you want to call it that. We all have a natural kyphotic and lordotic curves going down through our spine, right? Down at our lumbar spine, we definitely should have some lumbar lordosis going on. And then we go up through the thoracic spine and we get some kyphosis going on. And then we get some more lordosis up at the cervical spine, and down at the sacral, we're back to a little bit of kyphosis. So our spine kind of goes like this, right? Makes a nice little snake. But we can end up with exaggerated either lordosis or kyphosis. And when we have that, our posture gets thrown off. Scoliosis is the next one that's kind of important. So if kyphosis and lordosis is anterior posterior, then scoliosis is right left, right? So normally if you have a spine, your spine should be mostly straight going all the way down. That was not supposed to be there. My mouse hit the mouse pad. If you have a scoliotic curve, you're going to have one that's called a primary curve. So if I have a scoliotic curve, maybe down here in the lower thoracic and upper lumbar region of my spine. So we'll say this is T, and down here we have L, and down here we have sacral, and up here what? That wasn't good. This is why Mr. McKeever should not draw. So down here we have our sacral region, way up here we have our cervical region, right? If we have this curve down here in our thoracic and lumbar region, that's going to be what's called our primary curve. And we're going to see some great x-rays of this in a little bit. Well, if I get a curve, and this is going to my right, so my primary curve is to the right, somewhere further up here, I have to have a secondary curve to kind of correct my balance. And so now I got a secondary curve higher up. And oftentimes you'll find is there's smaller tertiary curve or a smaller third curve lower down that goes along with that, because the goal is to keep that vertical line of gravity going down through the spine even as possible. It's really bad if that gravity line is going down just through that curve, because we're going to be way off balance. Then, like I said, we'll look at some x-rays coming up that have some really kind of wicked curves to them that I found. But does that make sense? So when you have, it can be tremendous, it depends. So let's say, if my scoliotic curve, my primary curve is in my thoracic region, which is pretty rare because of the way things are set up, then my secondary curve is going to be below it. Like if I have upper thoracic scoliosis, like in T1 through 5, usually then the secondary curve is going to be in the lumbar region. But typically where you see that scoliotic curve, the primary curve is down kind of mid-thoracic to upper lumbar, and then it's usually above. Yes, usually, Amanda made a good comment. It's a secondary and tertiary curve usually on the same side. Usually, yeah. If it's not, it really is going to throw off your balance. And that we may end up with a bigger problem, right? So what if, instead of this, I've got a curve here that's my primary, and for whatever reason, I got a secondary curve going to the same side. That's really going to throw my spine off. And then in this region right here in particular, I'm going to have a lot of impingement. So typically, the tertiary and secondary are to the same side. Well, with scoliosis, we're not talking normal. Kyphosis and lordosis, we can have a normal kyphosis and a normal lordosis, or we can have exaggerated kyphosis, right? If I'm like this, and I look like, what's the guy, Quasimodo from the Notre Dame movie, right? That's an exaggerated kyphosis. But scoliosis is typically abnormal. We have a slight deviation in our spine just from posture and growing up and stuff like that. But a true scoliotic curve is abnormal. A lateral curve is typically abnormal in the spine. And we're going to figure out why it happens. So these are kind of some of the pictures we talked about last time, looking at kind of a lateral posture, what happens. When we're looking through it, we should have a straight line that passes through the earlobe, through the acromion process, through the lumbar bodies, through the greater trochanter, just behind the patella, so right in the kind of that lateral epicondyle region, and then just in front of the lateral malleolus if we're looking at a side view. If we're looking from the front, that should kind of bisect the midline of the body. The main portion when we're looking from the front is not so much is the line going down the median, is everything on the level as we're going down, right? Is the head level? Are the shoulders even? Are the acromions at the same height, right? As we go down the ribs, can you find the ribs at the same height? Then we get down to the pelvic crest. Are the pelvic crests looking like this, or are they even? Where are the ASISs? And then what do the feet look like? And what do the arms look like? You see this guy, his hands are kind of even down to the side. Thumbs are facing forward. If you ever look at me, and because I've got really bad posture with my shoulders, the way I sit, my arms are almost always severely internally rotated. And like to the point that my thumbs are almost always backwards. My feet, I won't even talk about. I don't have slight toe out. I have penguin feet. So we'll talk about that then. And posterior view, kind of the same thing. We're looking for everything we look from the front, now from the back. So let's look at some posture here. And this one's just a stock photo from, again, the Alinabod site, which is the Alinabod is usually the tool we use for posture. When we look at these patients, what can really help us is if we take a line and draw it right straight down the middle of their body. So I know the picture's a little blurry. It was not a very good quality photo here. But looking at this patient, if we're looking at them from a standpoint and just kind of doing an analysis of them, again, we're not diagnosing here, right? Because this would be one thing Dr. Reskin will be quick to hit on. She'll say, we're not diagnosing why they have the problem as PTAs. We're just saying, I'm seeing this. That's a big difference than going, oh, well, his shoulders are low because he has this problem. We're looking at it going, oh, okay, so this is kind of where we're at. If we look at his earlobes, right? So that's passing through the right earlobe. The left earlobe's slightly higher. Do you see that just a bit? I mean, it's really hard to see, but it's just a little bit higher, like maybe a centimeter. And that could be the day's weird shaped earlobe. So I'm not really worried about that. But if I look at this bisection of the head, right? The bisection of the head itself is not bad. The head posture looks pretty good on this guy from the front. Now, when I get down to the shoulders, this is where we start making our money. Because now we're going to look at the shoulders here, because there's his acromion on one side. There's his acromion on the, oh, that was not what I wanted. There's his acromion on the other. Pretty even for this guy. I think they like picked this guy with like the best posture ever. What do you think? Looks pretty even? Anyone have any comments?
Yes.
I don't think it looks even.
Okay, what are you seeing? Tell me what you're seeing.
I mean, I just feel like maybe his right shoulder is a little bit more elevated than the left.
Good. Yeah. I'm looking at that going, man, that right upper trap kind of looks a little tight, is what I'm kind of looking at. Little sloped on the left, exactly. And that's probably because he's kind of hiked on that right side. Why do you think he's probably hiked on the right side? We're not diagnosing again, but what probably clues you into why that right side might be a little tighter? Probably right-handed. Yeah. Right. We're all going to see when we kind of look at each other, you know, and mine has shifted because I used to be left-handed before I broke my neck. And I know this side was always hiked up compared to my right side. But now because I've had to shift to right-handed, it's changed. I guess it's kind of balanced out now. I don't know. I would say he's, for the most part, he's pretty good, but he is a little bit more sloped on that left side. Now, what would really help us here is if he's not wearing a t-shirt. Right? This is one of the things I'm going to say is when you're doing body measurements, the more skin you can see, the better you are at analyzing posture. If they're wearing, you know, a full-on, you know, super like druid cloak with hood and everything, you're not going to assess their posture at all, right? It's usually best for a man to be shirtless if you can with shorts that are appropriate that you can see the kneecaps. And for a lady to be wearing shorts and potentially a sports bra so you can get access to all the kind of major points we need to point at. And we have a couple of those coming up that make it a little easier. And if you look at that elbow, carrying on from up here at that shoulder, I want to thicken this line a little bit. There we go, line thickness. If you look at that elbow, carrying on from that shoulder point, you can see that that left elbow, or that, what's that fossa called on the inside of your arm? This fossa here?
Olecranon fossa.
Well, the olecranon's out here.
Antecubital.
The
Antecubital fossa,
sorry.
there we go, good. The front side of the arm, right, antecubital. His antecubital fossa on that left side is a little lower than the right side. Do you guys see that? Just a little bit, but that probably ties into, again, this stuff up here. So now he's kind of definitely got a slope. Well, if I've got that slope, then my spine's kind of going to be a little bit off as well. So I got to keep an eye on that. We can't tell with ASIS because we really can't get in here and see them. That doesn't help us much. But I can look down here, and the bottom of the patella, he's pretty even. So that means somewhere in the spine, he's corrected himself. What would you say about the width between the knees?
He's a little bow-legged.
Right. He's a little bit bow-legged, right? And we'll talk, did Dr. Johnson talk about what that's the technical term for that is called? Because bow-legged just sounds bad. Verum. Well, here it's verum, right? This is genu meaning what? I'll give you my hint. Genu meaning knee, right? And varus, or verum, right? The way I always remember it is, if it's there, it's very wide. That's the way I remembered it. What's the opposite of varus? I see it, oh, Amanda already wrote it, right? Genu valgus. What's the other term for genu valgus? If you got bow-legged for wide knees, knock-knee, good, yes, right? And the way I remember that is valgus, the leg forms two L's. So val, L, see what I'm talking about now? These are my silly ways of remembering these things. And we're going to talk about what happens when he has genu varus down here, what happens down here at the ankles, and then what's going to happen up here at the hip. Because we're going to have to correct for that in order to have fairly normal posture. So when you're looking at this, we've got those definite wide. And now if you look down here, look at that. I'm going to clear a little bit of this because I've got a lot of drawing on there. So let me get my little eraser here. You can see how this, yep, go ahead.
And you said the PT does this assessment, correct?
Well, we can do the check of it, so we can report what we find, but the PT is going to assess it and say
Okay.
he's got genu varus because his femoral angles are off, or something like that.
Okay.
We'll talk about more about what causes that problem in the future here. But if you look, because he has that varus at the knees, look what it causes down there at the ankles. I think I want to pick a different color because that doesn't show up very well. Red probably will show up a little bit better down there. Because his knees are kind of out wide, his ankles now he has knock ankled. That's not a term, but he has valgus at the ankles now because of this. It's wild how that happens. And then also at the hip, he gets probably a little bit of valgus as well. We'll see when we talk about, when we actually analyze people like this, but it's going to affect their whole posture. What about his feet? Are his feet fairly flat and planted well there? And feet look okay. He's not really wide, not really narrow. Oh, I'd probably say narrow base of support, but that's because of the valgus at the knee. But he's definitely got some minor problems. Would you say he's the worst posture you possibly could see?
No, not at all.
Yeah, no. I mean, he's probably got some postural issues. He's probably got some tightness in that upper trap. Maybe has some problems with his knees. But overall, this dude looks fairly well, normalized. Now, if he came in and is not having any problems, it's like, no, I really don't have any problems with my knees. I don't really have any problems with my shoulder. I'm just being seen because I tore my rotator cuff. This postural assessment may not be needed, right? And honestly, if we start fixing things that we start seeing, and he's lived with it so long, a lot of times we can actually cause him more pain as he adjusts to the changes we're making to him. So we've got to be careful. Let's look at this young lady. No one ever smiles this much when they're getting their posture assessed. I'm just letting you know that. So this young lady is sitting here, and we're going to look at her posture now. So we got the alinabod here. I'm going to start from the top of the alinabod, and we're going to come straight down that line. So we come down between her feet. It's a little off towards the bottom, but for the most part, we're on there. Is she aligned fairly well with the alinabod at least? Bit of lordosis. Okay, good. We're starting to see some ideas. Good, Riley. Let's look from the front first, then we'll go to the side view. Overall, yeah, we got some forward shoulders. Good. We're starting to see some of this stuff. What do you see about the width of the feet that's different?
They're wider than her hips, which is kind of unusual.
Okay. What about the space between the midline for each foot?
It's uneven.
Yeah, it's uneven, right? So there's that one. And there's that one. So she's got a little bit wider stance on that left side. Okay, so that gives us some clues, which when we look at some of the other stuff, it will actually give us some clues. Earlobes, well, we can't really see that left earlobe very well, so we don't know. We just gave her a mustache. Earlobes, I mean, for the most part, I can't really tell much with this if it's any more uneven than it is without actually seeing a better picture of this. But let's look. So here's an acromion. And so if that's the one acromion, the other acromion is down here. Definitely got some difference in the acromions, right? We're a little off there. So we got one kind of same posture as the last guy. Again, probably hinting at she's probably right-handed.
Can it be from like a surgery as well?
Could be, sure. Yeah, could be.
'Cause I feel like my shoulders are not like because of my surgery.
And that's going to cause a muscle imbalance, right? Well, honestly, even the being right-handed causes you a muscle imbalance, right? If I force you tomorrow to basically take a belt and tie up your right hand, if you're right-handed, or tie up your left hand if you're left-handed, and only use the opposite hand, is that going to be weird for the day?
Very.
Yeah.
Yeah.
Has anyone tried, if you're right-handed with a mouse, try using your left hand for a mouse? Because now your clicks are different, right? It gets weird. It feels weird, especially if you have a right-handed mouse and now you're trying to use a left hand on it. It gets all funky. So yeah, it just feels weird. When I was in the martial arts, my instructor actually had us for 2 days. Anything that we would normally do with our fingers, we were supposed to use our feet for. So turning on and turning off lights, we were supposed to hold our balance to do that. It was really bizarre, but it really made you realize how much we use our hands. Eat with your toes. Yeah, I can't get my leg that high. It's not happening. I'm just going to starve for the day. Maybe Dr. Sokel and Dr. Reskin could use a fork with their feet, but not me. I'm just going to starve. I'll eat like the kid from Christmas Story instead. Color with the opposite hand, etc. It stimulates part. That's not a bad. I don't know the research on that, Amanda, but it's not a illogical concept. I don't know much about it. It wouldn't be illogical to think that using your other hand to stimulate it. Brush my teeth, left hand. That's my problem. I never thought of it. It's all because of my left-handed brush my teeth that I get the cavities, not from the Coke.
So, Mr. McKeever, for the aligner like, since you were talking about like the space between the feet.
Yep.
From the midline, do we have to worry about like, where their hands are, like if it's wider than like if the right side is wider than the left, or like?
Well, so we're going to do from a PTA standpoint, we're just going to document what we see. When we put them at the line above, what we're going to try to do is try to get their nose lined up with that center line of the alinabod. What we're going to do is actually, and you don't see it here because they don't have it hung, there's going to be a plumb line that hangs right down that middle line. And she's going to stand behind that plumb line. We're going to get her nose lined up with it and then tell her to stand relaxed, which is really hard when you know somebody's assessing your posture, right? But you're going to tell her, take some deep breaths in and just relax, because we don't want her automatically thinking, oh, I got it. Okay, fix my shoulders, head back, right? We want to see what her natural posture is going to be. And so, yeah, in this case, what I would document is that that there's a definite discrepancy between the right foot stance width versus the left foot stance width, if that makes sense. I'm not going to go, it's 2 inches versus 6 inches or something like that. There's just a definite difference. And this is why it's beneficial when you're doing a postural assessment to take photos like this of the patient, because then you can put those photos in the chart and it helps you, right? I can take out my tablet here that I've got sitting and make little notes on the photo that go along with my notes that I'm going to put in the SOAP note. One thing I notice on her, when I come just a little bit lower, her rib cage is not very even.
Would that also?
I'm sorry.
Never mind.
Nope, go ahead.
Like the space between her her elbow and her stomach?
Yeah, right. What I'm seeing, and somebody mentioned before that she's got some forward shoulder. What I'm looking at is I think she's got a little bit of anterior rotation here on that right side, right? Which has caused more space here than here, right? So she's got a little bit going on. Now, again, she definitely does not have the worst posture of any of these pictures. Belt line, we're starting to correct a little bit because this side over here is a little bit higher than this side over here, just a little bit, which then leads down to the leg problems, right? Now let's go down to the knee here. So that's the bottom of the patella. Over here, we're kind of going through mid patella on the left side, aren't we? You guys see what I'm talking about? Because let me draw patellas on here for her. So there is patella 1. There is patella 2. Well, if she shifted, that's going to happen. As far as feet being turned, the feet are turned pretty evenly. I mean, this one's a little bit more forward than this one over here, but for the most part, again, not horrible. But now we start looking at this lateral view. Now we start seeing where all of those anterior problems we're noticing are coming from. Oops, that's not that one. So let me get up here to the top of the alinobod. Draw it the whole way down. So remember that center line, and it could be, again, I'm gonna chalk this up a little bit of an asterisk because I think this person didn't line her up the best. Because when I'm doing this, I'm gonna line that external auditory meatus or the ear hole right up with my center line of my alinobod so I can compare off of. But man, that acromion process is way forward here. And it's definitely not in line with the ear. So she's definitely got some forward rolled shoulders going on, right? Now, ladies, do you think you have a chance to have a greater forward rolled shoulder than men?
Yes.
Yeah, right? That's just for a couple reasons. Number one, your shoulders are designed for carrying who? Well, that too, breasts, yep. And then what goes along with breasts? You're designed for carrying baby, right? Swaddling baby closer. There's some female anatomy that's designed that. When we find out about the hips, we'll see how the hips are changed and that structurally between a male and a female on purpose. Yeah, she's probably got some tight pecs, right? Yeah, that happens. It's amazing when you bring the patient in that's got like cervical pain and you have them do a door stretch, a wide door stretch, and they're just like, oh, why did no one ever have me do this before? This feels so good. Because those pecs just tighten up. Remember I talked about that internal rotation of the hands? She's definitely got some internal rotation of the hands, which ties right back up to those forward rolled shoulders. I can't tell if this passes through a greater troch or not. I'd have to get hands-on and actually feel, right? And remember, when we start palpating patients, this is not the way to palpate patients. We are not pokies, right? Pokey stays with Gumby, right? Big flat surfaces. You want to palpate with the palm, you know, the major surface of your carpals here, metacarpals, right? Because that gives a broader surface and you can find those nice pointy body surfaces a lot better than just poking. And not only that, but if she's tight and you start poking, what's going to happen? It's going to hurt. It's not going to feel good. On top of that, if it's any given concept, you start poking around and you're going to get somebody that's ticklish and they're going to jump all over the place when you're trying to actually measure stuff. The line does pass posterior to patella, so we're okay there. But man, look down here at the ankle. Way in front of that lateral malleus or that lat mal, right? Whew. But that also ties, somebody said already, look at that lordotic curve she's got. And if she got that lordotic curve, then she's going to have an accentuated kyphosis up here to kind of balance her out. Now, we all have a natural curve there, right? But this one's a little bit more accentuated than normal, right? And then kind of the sacral curve goes along with it. I know this seems weird, and analyzing other people's bodies. Yeah, she has a little bit of hyperextension of the knees. I don't know how much, but it's probably a degree or 5. And we're going to find somebody in here that's got some wicked hyperextension. I guarantee it. We always find someone that's got wicked hyperextension. And Mr. McKeever gets nauseated. All right, so this one we've got a little bit worse off posture. So without me drawing any lines, what do we see? Just looking at both of them. Doesn't matter if you're looking at the anterior, posterior, or lateral. What are you seeing? Shoulders, hips are off. Good.
The width between her knees.
Yeah, right. The width between those feet. Look at that, kind of the hips. Hips are way off, aren't they? Right? Does she have a little bit of forward head? Geniveris, good. Now, with her, I'm going to guess a little bit of that genu varus is naturally because of the way the female's hips are angled. She doesn't have total varus yet, but she definitely has some genu varus going on. Definitely has some tight muscles, generalized tightness in the muscles, right? She's definitely hypertonic. And that could be, we have to figure out in this case, is she hypertonic because she's got a problem? Or is she hypertonic because we're looking at her posture, right? So if I put Riley up in front of this line of bod and have the whole class look at her, is she probably going to have some body image issues? Probably. No, not at all, right? I did this with me once, and people are like, how can you just be so relaxed? I'm like, because I know my posture is horrible anyway, I just give up. I wish we could see behind this arm here a little bit, because I really think she has a pretty lordotic curve here. We just can't see very well because of the way the arm is. Internal, external rotation of the arms look fairly decent, right? But man, she's definitely got some issues going on with her, right? I'm just going to take and draw that line straight down again. Boom. We've definitely got some issues in posture. She looks like a gymnast. It's quite possible. I don't know. This is generic photos because I was going to use previous cohort photos, but I figured that I did not get permission. So I'm going to use ones that are freely available on the internet. Swimmer, possibly, yeah. Definitely, my main thing is I'm looking here. This is totally uneven. So if that's uneven, that has to correct that way, which then the knees correct that way. And her head slightly slopes that way. So she gets a whole mess of stuff going on.
So, Mr. McKeever, I know this is kind of not what we're at right now, but like when you see someone like this that's like has their body correcting like back and forth, like how do you even begin to untangle that?
Well, so that's a good question. So that's when we go, okay, where is the chicken and where is the egg, right? And on this part, everything could be a chicken and everything could be an egg. So what I'm going to do, if I'm going to work with her, is I'm going to come up and the first thing I'm going to do is adjust her shoulders. I'm going to put my hands on her shoulders. I'm going to say, okay, relax for me a second. I'm going to adjust you. So I'm going to adjust her shoulders. Usually if I adjust the shoulders, magically the head will straighten out because the head kind of goes with your shoulders. And then once I get their shoulders adjusted, I'm going to come down and it's exactly right. I'm going to start going down the body. So I'm going to go, okay, let's see the hips. And a lot of times, once I get her in a normal posture, what do you think she's going to say to me? How's that going to feel to her?
She's going to feel better?
She may feel better. But it's mainly usually the first time she's going to it's going to feel weird. She'll be like, yeah, she'll be like, my back pain feels better. But man, it just feels weird. And then we're like, well, that's because you've been spending so much time in this maladaptive posture that you're now in a normal posture and it just doesn't register. And so she's like, oh, okay. So that's when we're going to go, okay, so we've got all this kind of posture and the PT is going to go, I think the primary cause of our problem is X. And we're going to attack, like if she's coming for us for posture problems, I'm guessing the PT, if I was to hazard a guess, to what a PT would say at this, the PT is going to attack the hips because it's kind of easy to adjust the low back. The shoulders we adjust one time, but as soon as we let it go, she's going to go back to where she was. So if we can get the hips kind of in line and get her shaking and baking right in the hips, we can get the rest up. It's just like Shakira said, the hips don't lie. So if we fix the hips, we can fix some of the other stuff. When I'm manually correcting her, I start from top from bottom. But when we correct, I bet the PT is going to go after the hips in the back first. Now, it may be that the PT takes some manual muscle assessments and goes, man, all her problems are up here on her shoulder. And that's where we start. That's why I don't get paid the big bucks. I don't get paid the baby bucks. All right, we got another one here. Now, posture zone is just a generic form of the line of bod, just to let you know. The posture zone. What do we see with this one? Yeah, we got some varum going on here, don't we? And it's definitely causing the feet to be closer at the base, right? So she got a narrow base of support. Could that affect her balance? Good thinking, right? So this is how posture could play into balance, because maybe she's coming to us and says, I just have some really bad balance problems. It's just silly. Every time I wear sandals, she's wearing sandals in this picture, I feel really off balance. First thing I'm going to say to her is, what do you think?
Widen your base support.
Widen your base support. Okay, good. First thing I'm going to say to make things simple is stop wearing sandals. I'm just saying, if sandals are causing a problem, stop wearing sandals, right? It's like the person that says, every time I touch something with this finger, it hurts. Well, stop touching things with that finger. It's probably broken. But we're going to definitely widen the base of support for sure. Somebody else is saying something. Who's going to say something?
I was going to say her shoulders seem off.
Yeah, her shoulders are off, right? Now looking at her, I wish we had a side view of her, but we don't. She looks like she has a little posterior roll to shoulder. Yeah, right? She looks like she's a little rolled back. And I'm going to guess, because I know this one's from a PT, this is from one of the other PTA programs sites, that she is probably trying to correct herself to look upright in posture. But man, when she did that, everything else goes out of whack because she's not used to standing upright like that. And she's definitely back like that. It even kind of pulls her elbows back like the stupid, I think it's a Comcast or Cox commercial right now where they're talking about elbows back. That's kind of what this reminds me of when I see it. Her left shoulder's too low, good. Or lower at least.
Her hips?
Yep, hips are a little off, right? She has a little bit of rotation on her hips. I think if I look at it, because this button over here and again, this is not a fashion statement here, but this button over here looks a little more forward than that button there when they're supposed to be kind of in the same eyelet area. Left foot is forward, right? Good. But man, that varus has me going. We got some varus going on there, folks. That's some varus. Do you think she's got some tightness up here in these shoulders?
Yeah.
Yeah, right? You're going to put a hot pack on her shoulders and she's going to be like, oh my God, I love you. Because her shoulders are pretty tight, I'm guessing. I can't wait. I got some really good ones coming up here that you guys are going to love. All right.
He has horrible posture.
Oh man, this is one. Where do we start? Right?
His left shoulder.
Yeah, his left shoulder. Look at that left shoulder. That thing is like hiked up. Now again, could he be left-handed here? Maybe. So one of the things I ask when I'm looking at this is I'll say, it looks like he's about ready to walk away. He does not look. This is the way patients really look when you're assessing their posture. I'm just telling you. He's like, why am I doing this, right? Base of support wise, though, pretty decent base of support width. Why does he look lost? Because he's in a PTA program. I'm just joking. Base of support wise, width wise, I'm actually okay with it. It's a little wide probably, but I mean, this is probably one of the best base of supports we've seen so far as giving yourself right down kind of your shoulder width.
Would he have like an hyperextended knee?
He may, yeah. Which one do you think is hyperextended?
The left?
Yeah, left knee does look a little bit more hyperextended than the right. And I'm not so sure that he's hyperextended so much as he has a leg length discrepancy. And we'll talk about that coming up in a little bit too. But man,
so maybe his hips are off too then, right?
Yeah, right. I'm thinking that his main problem is this, that his pelvic diamond or pelvic pyramid kind of looks like that. And so now this leg's kind of snapping back and this leg's kind of popping forward. And he's just let's just face it, he is all off to the place. His hips are off to the right, good, right? He kind of looks like he's getting ready to punch you, doesn't he? Looks like he's drawn back for a haymaker here.
So, Mr. McKeever, you said like when the more skin you see, the easier it is to evaluate. Mm-hmm. So you ask a patient to be like, hey, if you could wear tight fitting clothes
Yeah.
Can you ask that kind of stuff?
Sure thing. And a lot of times we're going to have these postural assessment tools in a room. Because that way, like, you know, if your guy can take off, like, I'm not too comfortable taking my shirt off, to be 100% honest. I just don't have that six-pack ab going on. So yeah. But we'll ask the patient to take off their shirt, right? And ladies don't want to take off their shirt and have a sports bra underneath in the middle of the PT clinic. It just feels really uncomfortable, right? So we're going to try to keep his modesty a little bit. I also think those shorts probably aren't the most ideal shorts for me to tell. I mean, they're better than some of the other ones we've seen so far. But also, we're going to get hands-on, right? I'm going to get in there and I'm going to start finding stuff and palpating stuff and going, okay, there's that pelvic crest, there's that pelvic crest. But man, like those shoulders to me, that's like my major. I'm going, oh, good Lord, those shoulders are gnarly, right? Because I mean, if I just draw a straight line, let me get my straight line tool here. And I'm going to use that right acromion as kind of my guideline. That just shows you how far off his shoulders are. Maybe, yeah. If we found out, Joe, great idea. Joe says, would a shoe insert help? If we found out he had a pelvic, a pelvic leg length discrepancy, yeah, it may. And it's funny is we may put that leg length discrepancy in that little pelvic lift or shoe lift, and all of a sudden he's standing upright, nice and tall, and doesn't look like he wants to murder us.
Would you do like an assessment, a posture assessment, like on toddlers or kids?
Yeah, I do that a lot with kids. Because what can that tell me? That can tell me if they're developing normally. Right. And it can also, what do we know about scoliosis? Because you guys probably were assessed for scoliosis in school. The earlier we catch it, what? What do you think?
Because they're trying to prevent it, like to get worse.
It's easier to fix, right? If we can catch it early on and like before adolescence, right, and into adolescence, we can correct it. If we get to my age, and we haven't messed with scoliosis at all, it's really hard to correct because my spine is pretty much set in its stone at this point. It likes the way it is, right? A lot of you guys, you're young and able bodies. If we correct if you had a scoliotic curve and we corrected it, your body would eventually adapt to it as long as it's not structural. This dude, though, is a hot mess. I wish we could see the lateral view of this guy because I can imagine that his ears are all over the place. Look at this earlobe thing too. One earlobe's higher than the other. He's even got some facial asymmetry when I'm looking at it. I know, and not to pick on him, but he definitely has some facial asymmetry going on. So there could be multiple problems here that we're going to assess, and the PT is going to go, okay, so we're going to fix this. Now, what if this guy came to us and he's like, yeah, no, I don't have any back pain. I don't really have any shoulder pain, the hairline, yeah. My problem is my balance. Well, the balance may not be related to his posture, but it may be. This would be one where we'll chase the balance rabbit for a while. And yeah, look, I'm right there with you, man. My widow's peak keep creeping back. We may look at him and go, okay, so balance-wise, maybe not a postural issue, but maybe we chase balance and nothing's getting better. And so we come back to posture and go, well, maybe the balance issue is posture. Yeah, mine was really great today that I got hit. You can barely see it, but I dropped a book on my head and it split my head open for a while. It was great. Find out the older you get, the easier you bleed. All right, so now we got a posterior view of a student. This just looks like we're in Rustin Parr's house in Burkittsville, Maryland. She's facing the corner. No one gets that? No one? Tune up elbow, exactly. There's many friends that have said that. There's my vertical line. I'm going to come straight down. Left foot's further forward. Good. We're starting to see that. No one puts baby in a corner. So, a couple of things here. I'm thinking the person that aligned her or the person who's taking the photo is not taking a very good photo here. Yeah, she's got some
Her
problems.
shoulders look stiff.
Yeah, shoulders look stiff. The other thing I'm just looking at, like, this person should be shooting straight on. This is one of the things that, you'll find the more you do these. If I take my camera and I kind of hold it like this, or hold it way too high exactly, it's going to throw off my photo. I want to try to take my photo straight on. And the good news nowadays is we have photos or cameras pretty much everywhere, don't we? I mean, that's one of the nice things I actually like about having iPhones. Yeah, I think she's got some rolled forward shoulders. This one, I put this picture in here to tell you guys, this would be one that I would go, I can't assess this girl good enough, right? Because the photo itself is bad, right? So if you did this at the clinic, what would you want to do? Retake the photo, right? Reassess her, put her back in position. And this is why it's important. Yeah, not a top angle photo, right? This is not, we're not doing the selfie angle, right? We need to kind of take it straight on. And a lot of times what I try to do when I'm taking photos, when I'm doing especially vertical photos, is I try to line my camera up with mid-body. Because that way it makes it easier. And obviously if you have a real camera, I don't know where my real camera is right now, somewhere in the house here, probably over there. You have that lens that comes straight out. Yes, yeah. Maybe the person has some posture issues that's taking it, exactly. But this is why when I'm doing this, I'm going to take this picture, I'm going to bring my picture up right away. So I'm going to probably take, so when I take pictures, I'll take an anterior view, a right side view, a posterior view, and a left side view. And I instantly bring them up on a screen that I can look at. Because that way I could go, oh, the left side view was kind of crappy. Let me retake that photo. And I may even send, if sometimes with my patients, I'll send them home with their photos. I'll print them off for them. Yeah, Anthony, we may still do that in lab a little bit, so get ready. But this one here, this photo's out. We're gonna say this is a bad photo, and that's why I left that in there. That one's bad. Oh. Now, I will tell you this one here was intentional. This person doesn't have this bad a posture, but this is a intentional educational one here. They kind of positioned her to make her look off. So let's look at the anterior view. What are you noticing about the anterior view? What are you seeing?
Her shoulders.
Yeah.
The left one is it's more higher than the right one.
Okay, good. Her hips, right? She's kind of leaning, right? She's got a little bit of, what wrapper was that? She's got a little lean back going on there. Shoulders are definitely uneven.
Sorry, Mr. Curie. The space between the elbows.
Yep, space between the elbows is off. Good. What about placement of the hands? Is one more further forward than the other?
Yeah, left side.
Yeah, left side's further forward. Good. I'm looking at this clavicle angle too. I know this is a little bit more advanced than you guys right now, but look at this clavicular angle. That tells me her shoulders are uneven, man, because she's kind of like this. She's getting ready to come at me. Good. And that's thrown in. I mean, look at this, because if I was drawing a line straight through her, it kind of goes like this, doesn't it? That's kind of off. It's definitely not the way we want our posture to be. Again, she's smiling. I don't know why she's smiling. We're getting ready to roast her here. What about knee space, though? How do you feel about her kind of base of support and her knee space?
It's actually really even.
Yeah, that's pretty even, right?
I feel like it was corrected somewhere there.
Yeah, so she's correcting somewhere in her hips. Tummy's on point. Makes us self-conscious here, doesn't it, Diana? I'm just saying. Actually, pretty much most of her muscular structure, we got some goals going on here, right? Although she does have a little bit of chicken arms going on, I'm just saying. So yeah, the front view, we got some serious issues. Let's look at that side view. What do we got going on in the side view?
You can see like also her left hand is forward. So you can also see like from that there's something going on with her clavicle and shoulder.
Good, right? Forward head. Yeah, she definitely got some of that forward head going on there. Because, let me get my little draw thingy here. Straight line, not angular line. There we go. Because about here is her acromion. Her ear hole is a good, probably 3 to 4 inches away from their acromion. That's some forward head.
Well, also I'm curious about her hands. Like I feel like they're forward as well.
Yeah, I think so too. You're right. That she's kind of tilting her whole like arms forward almost, if that makes sense. I mean, again, once we get to pelvis, it kind of levels out, doesn't it? So once we get down to like our hips and start going lower, I mean, overall, it's probably passing pretty close to a greater trochanter. It's probably posterior to the knees. I mean, and it is just anterior to that lateral malleolus. And that's that plumb line I was telling you about. See how it's got that little weighted thing here? I will be careful and not let any of you mess with that, because I once had somebody think that's something to spin around in the room. And no, you guys do not get to touch the plumb line. It is not a Middle or Eastern weapon of attack. It is a plumb line. Okay, so just hypothesize here. Why do you think? So Riley says it's weird that her upper body is so out of whack, but her lower body is balanced. Why do you think that is? Any ideas?
Maybe a desk job?
Could be a desk there. Yeah, good idea, right? She's in the PTA program now, and she spent all her life back behind the cage at Caesar's Palace. Could be. Right?
So it like be like a muscle imbalance, maybe?
Very good, right? And so when we got down here to the lower part of her body, she's actually self-correcting herself, right? And maybe we fix this up here, and all of a sudden we realize this down here wasn't as pretty as it was, right? We fixed her upper torso, and all of a sudden now her legs are out of whack because she's just been self-correcting down there to keep herself more neutral down there. She's like, I've got to maintain my nice low back curve and everything like that, but doesn't think about the upper body posture, if that makes sense. Because we all do that, right? We always worry about our, lifting with our legs, worrying about our low back, and then we totally forget about our upper body entirely. But that's definitely, we got some serious, you guys are doing good at this. I'm happy with you guys. Let's see what we got next. Oh boy. Oh my.
Did you do that on purpose?
No, so this is not on purpose.
Oh.
What do you think the problem here is? Scoliosis. Good. Right, this girl's got some scoliosis. Now, I'm going to use this as an example. Now, do you see how having a little bit less clothing the way really gives you a good view? That you can see all the body landmarks going down, and it helps you kind of diagnose a little bit better? Yeah, right? And remember, this is not meant for you to be awkward, right? You're not looking at their body in that way. You're looking at their body from an analytical perspective. So sometimes you have to convince your patients of that. Like, look, especially for a guy, if I'm assessing a female, sometimes they're like, yeah, you just want to get me down into a bikini because, right? No, I actually need to assess landmarks. I need to see what I'm looking at. It really does help. Just this view here, you're like, wow, I can see so much, right? I love how they drew all the angles on here because that's just what I wanted to see, right? Because that just makes things worse. But when we're looking at her, man, oh man, we got a curve going this way, got a curve going this way. Right, so we got some serious curvature going on in her spine. Right? And that's got to be uncomfortable. But the funny part you'll find out is, because I'm guessing she's probably in her late teens. I don't know how old this person is. She's probably adapted to this. And it's not as bad, it's not as uncomfortable to her as I'm looking at this going, my back hurts looking at this. Does anyone else feel that way? Like my back's starting, I'm going, I don't have great posture, man. My back feels good. Especially that front view. For some reason, the front view really hits me hard because I can see that linea alba. Grips don't lie, you're exactly right. But I can see that linea alba and look how kind of an angle it is. But man, it just, like if I draw a straight line down through her main torso here for the anterior view, let's draw that straight line coming down. Boom, just look at that. Trying to fix my whole posture, exactly, right? After this, you guys will be totally conscious of it. And you know what? What really helps is have your significant other or one of your family members stand up against a blank wall and just have them relax and see if they'll let you take a picture of them and look at it. Because you'll find a lot of your significant others, especially, you know, if you've got a significant other or if you've got a family member that's willing to be your guinea pig, like, oh boy, we got to fix your posture here because we got some issues, right? I had one that last semester, they're like, I told Ate to stand against the wall and man, her posture was bad. That's been the interior. Shoulders back, soldier. So what do you think she's going to feel like walking?
I mean, I don't mean this in a derogatory way, but probably lopsided.
Yeah, right. She's going to she's going to have a little bit of probably a hitch to her gait, right? Because her whole body's going to be thrown off. Now, if we can correct this, what we're going to actually do for her is we can actually, and we'll talk about this when we get to the spine, we can put a brace that puts pressure there and puts pressure there that will straighten up her spine. Now, this is as long as it's not a structural problem. You can have some structural problems that, you know, if her spine is, the problem is she actually has breakdown of the spine or she has bony blocks, that can only be fixed by surgery. I'm hoping this is postural and we can fix that. Right? But we can put a brace on her and all of a sudden, once we put that brace on her, the rest of her posture will fix itself. It's really wild when it happens. It's going to be really uncomfortable to her. But, you know, for example, like this, we had one like this back in Pennsylvania that she had scoliosis and she was, you know, she started seeing us at about 15. And her goal was she wanted by senior prom to have most of her scoliotic curve fixed so that she could get a ball gown that actually fit her properly. Because it, you know, think about even getting clothes, like tailored clothes for this when your back's looking like that. Is that going to throw some things off? Sure. Right. And that was her goal. We got her in a brace that specifically was designed to kind of fix the scoliotic curves and got her exercising to fix these curves because there are some exercises we can do for it. Yeah. Goes to show you to look everywhere, right? Now, as far as her feet goes, her feet don't look too bad, right? As far as spacing goes, maybe a little narrow base of support. And that just shows you that it's all up there in that top portion. That just is amazing how bad that is. See some scoliosis here? We got some problems?
Yes.
Yeah. Wow. That's a good comment, right? What amazed me about these photos, and it's primarily the guy. Look at the difference in the skin folds on that guy. That's pretty significant, right? That is enough to cause lung problems and breathing problems, right? That could be really significant for this guy that, you know, he's always had problem, you know, I've always had a problem with asthma or something like that. Well, it may not be asthma, maybe that his lungs can't expand. I don't know what this lady here with her hands, she's like doing some sort of ballerina pose here for us, I think. I'm not sure. That one always makes me giggle when I see that photo. For some reason, I don't know what it is about it, but it just kind of makes me giggle. But her, even look at the scapulas. Good Lord, they are way off. And again, here, this one to me I don't know what it is about her upper back, but her upper back looks painful. It looks like she has, so first of all, she's got some, and we'll talk about this, she's got some scapular winging going on. So what that means is her scapula are kind of tilted upwards. And so that inferior angle is kind of pushing back against the spine. I don't want to talk to you. Does anyone know what muscle's weak when you have scapular winging? What muscle holds your scapula?
Rhomboids?
That actually helps pull it backwards. What's going to help pull it forwards? It's going to be more on the anterior surface of the body. Not pecs. What lays underneath pecs, that's kind of a sawtooth muscle.
Serratus anterior?
Yeah, serratus anterior is the major one. If I see her, one of the things I'm going is we're hitting serratus punches hard. And serratus punches are where you put your arms out. We'll do these actually on tomorrow. Where you put your arms out straight and you protract your shoulders heavily. Right? We used to call those when I was doing helping with push-ups in the clinic, we call those push-ups plus, where they would go into the full push-up and kind of pop up out of that push-up and then drop back down, because that was a serratus punch. The guy's foot's way off, yeah. So which one? So we got, I said somebody saw a genu valgus, right? Oh boy, we got some genu valgus. This is the first picture we've got some genu valgus going on. Definitely, we got some knock knee going on, right? And so this would be one. Well, is the knock knee caused by the spine, right? Or is the spine caused by the knock knee? Ooh. Right? That's why I'm glad PTs have to do the diagnosis and I don't. I just have to report what I see. One thing I see here, and I don't know if you guys can see this. Do you see how this foot's kind of rolled in? And this one's kind of flat? She's definitely got an overpronation on that on this foot here. And the guy, man, he's got the opposite. He's got some supination going on that outside foot.
The lady with the black pants, kind of.
This one here.
Her, yeah, like her butt's kind of out.
Yeah, she is. She kind of got that badonkadonk pop going on, right? As I call it. So what causes that? Maybe this uneven distribution of weight. Good job thinking, Riley. Right? What curve is she extenuating that's causing kind of that butt to pop out like that?
Lordosis.
Yeah, lordosis, right? She's doing pretty heavily anteriorly tilted pelvis, right? She's taking those pelvics, and so she's got them tilted down like that. So now her back is all knotted up, and she's going to come in and going, yeah, you know, every time I get off work, my back hurts. And you're like, duh.
I hope that the PT on the guy told him to stop sitting with his wallet, because that's going to cause one side to be hiked up.
That's a fantastic observation. But we don't think about that. How many of you guys have ever thought about how, and maybe ladies too, I'm not going to exclude you if you carry your wallet in your back pocket, but guys do this traditionally. How many of you guys have thought about what your wallet does to your posture? Is anyone going to say that? Okay, so Anthony says he does. I didn't think about it. So hold on here, Leaf. Where is my, you know, a stack of cards like that, and that's not all credit cards, it's just like cards for the casinos and cards for hotels and stuff like that. You put a stack of cards like that in your wallet. Think about putting in your purse, right? Purse is another thing. When you just barely have pockets. That's great. But I had a really big, thick wallet a long time ago in a land far, far away. And I was the type of person that put everything into my wallet, right? And you guys probably have a friend or two that are like this, or maybe you are like this, that you have to carry every single card you own in your wallet. Is anyone willing to admit that? I did. I used to. And then I went down to a minimalist wallet. And do you want to found it was funny? When I went to a minimalist wallet, I had less back pain. Because I didn't think about how that wallet affected my butt. And how, when I sat down, I kind of sat down like this because I'm sitting on 3 inches of solid cards on my right side. Right? Or think about all those high rollers downtown when they break out that wallet and that wad of cash. right? The other thing I've also realized now is it made me less likely to be pickpocketed because now I can carry my wallet in my front pocket and it doesn't bug me as much. But yeah, man, that wallet, I'm just looking at that bulge on it. I mean, look at his pants. His pants have clear wear from that wallet going in those pants. If that's worn out, then so's his butt cheek. Merce, yeah. Or what's the one called that goes across your belly? I don't know what that one's called. It's not talking about the fanny pack.
Satchel?
What'd you say?
Satchel?
A satchel, but there's one that actually straps across your belly, like that's not a fanny pack, but goes under your shirt. I've seen them before for traveling. Just like especially if you're traveling over in Europe and stuff like that, or for me, I've been in like Dubai and that, and there's a lot of pickpockets. I think now I've got some of the X-rays, so let's look at this once, just so you can see kind of what's going on. Look at these spines. So the one on the far left here is probably the safest. Because that one, it does have some scoliotic curve going on, but it's not as bad, right? So first of all, are we looking at, I know it says at the top, never mind. I was going to say we're looking at X-rays or MRIs, but it says at the top that we're looking at X-rays. Good job, Mr. McKeever. Look at how, just in this one here, looking how that spine just goes, whoop, whoop. So I think it was John that asked me, do the curves match? This patient here I'm looking at, this is a primary upper thoracic curve. That means this curve down here is my secondary curve because of how big that hump is. And again, not big in this case, but bigger than the other humps going down. Look at this. Straight, 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 wham. And now this person doesn't really have a secondary curve. This person only has a primary curve. That is going to be really uncomfortable because they have nothing fixing them further up. Can you see how that's affecting the space in the vertebrae? So what do you think that's going to cause?
Problems with breathing and like ambulation, etc.
Yeah. Not only that, but because this side over here is more open, so this is the right side, so this is the left side over here. Because that left side of that spine is more open, because this disc is jelly filled, it's going to protrude that way and go, right, Ryan said herniations and lead to pinched nerves like Christina says. Yeah. Right? So now this patient's coming to us and going, man, this leg keeps going numb on me. And when we look at the X-ray and go, well, I don't ask why. I use the famous Dr. Phil phrase. I don't ask why. I ask why not. Going down, bad spine here. Here's one with a really pronounced curvature. Look at that S. That is a S curve if I ever saw one. The other thing I'm looking at is we got something going on here on that pelvic crest. I don't know what yet, and I'm not going to diagnose, but there's some definite air in that that pelvic crest that worries me. But look at how it affects even the space in the ribs. It just amazes me when you see this, how even a small curvature of the spine throws off everything, right? How did they test kids for scoliotic curves? Do you guys remember from way back when you were in school? Did they still test for that?
I think you touch your toes and they run their fingers down your spine.
Yeah, right? That was the creepy nurse that came in and like, touch down to your toes. And they're like, I can't. And then they ran their finger right down your spine to see if it kind of did one of these numbers, right? And then, it used to be, at least in my day, if they detected that, you went to physical therapy. It's not as common anymore. Like they're like, oh, well, so it's minor. Well, that minor can go really quick to something like this if it's not taken care of. Even up here, I'm looking at some of the space difference here in those clavicles just because of that scoliotic curve in the spine. That is just, I don't know, does that scare anyone else looking at those? Like makes you feel better about your spinal posture, I think. Got a couple more here that look bad. This one, this first one. Look at that. Do you think we're going to be able to fix that one? So, okay, so good. Riley says, are we going to be able to fix these patients, or how do we help these patients? With this patient, or with a lot of these patients, what we're going to have to do is back bracing. How's there room for the heart? Right. Right. So maybe they're going to get some, you know, instead of cardiomegaly where their heart gets bigger, the heart's actually going to shrink, right, and get atrophied. But in the case of this one here, I don't think this one we can really help. I'm going to be 100% honest. This one is probably a structural deformity that's going to have to see a doc. Right? And I don't even know if the doc can fix that. Did Dr. Sokel still include the pictures of the one kid that I treated with the surgical incision on his back in the patho class about this? Okay, I'll show that to you before the beginning of next class. I have that. I have a kid that I treated back when I was in Pennsylvania that they fixed his spine. And when you see all of the work they did on it, it's terrifying because he had like a 45-degree spinal curve in his spine. And so they literally had to go in and basically, they had to go in, and that's what they did. You're exactly right, Anna. They went in and they broke his back basically and put rods the whole way down his back. And now his back is basically fused. If I remember correctly, it's fused from T1 all the way to L4. Now, the good news is they waited till he had at least reached mature height before they fused him. Like it wasn't like they fused him at, 5'1". He fused at about 5'7", 5'8", but that's all the taller he's ever going to get. This one, not so bad. But man, just looking at these. What's going on here?
She must have or he must have really tight neck and shoulder muscles.
Okay, but I'm really talking about what's that white thing?
Wedding band.
What's that? Wedding band. Good.
Yeah, I was gonna say metal. Yeah.
Metal. Yeah. Right. So don't freak out when you see that. This patient's standing like this. What's that doing in his body? It's a wedding band. Right. I have a great picture of, like I said, when we get to the pelvis, I'll show you the picture of my my wife that passed away. When they did a picture of her pelvis, and there's some metal in the pelvis, and people are like, how did that happen? It's genes. But yeah, so that's metal from a ring. He's standing kind of like this. What they're doing is holding their shirt up while they're holding the radiation cloak thing that's protecting them. But man, look at some of the organ shapes because of this, right? That's definitely going to affect things, isn't it? I think I have one more. Is that it? Let me see. Oh, go off there. I like this person's pose because I'm that way about this spine too. You see the bronchioles, yeah, right? But man, this spine is going to definitely affect the heart and the lungs, isn't it? The way it's affected. Man, look at that. That was about how sharp his curve was that they had to surgically fix. And it just goes down. And even when you get down here, look at those pelvis. The pelvis is now oblique, right? The actual pelvic opening is oblique. So you may end up with, it's funny, is patients that have scoliosis often develop bowel and bladder problems and incontinence issues because of this. Was that interesting? Is that a little bit better than like sitting, staring at a book in lecture constantly for 4 hours, right? It just goes to show that, when you're looking at the patient, it's not always, you're not always going, okay, well, yeah, it kind of looks off. No, check it, right? We'll look at each other a little bit when we get to the lab because I really want to do that just so we can kind of get hands-on and going, okay, somebody can partner with Diana and go, okay, so there's her ASISs, there's her chromiums, there's her ear holes, kind of get an idea of getting hands-on with the patient, not hands-on like this because that looked bad. hands on like this with the patient. We do have a little lab tomorrow. It's going to be virtual, so you don't have to go in. We're doing a virtual lab tomorrow, so you don't have to wear your polos tomorrow. Wear like tank tops and shorts or something comfortable, because we're going to do some exercises tomorrow. We're going to practice some exercises, so we're not going in lab. Jammies are fine. Jammies are okay for tomorrow. I'm not going to yell at you for wearing type stuff like that for we're moving stuff, because we're going to do some of the basic exercises. I don't know if you guys can see, but I've got a second camera pod set up over here so I can kind of broadcast the floor so I can demonstrate the exercises. You guys can do them with me. I'm going to stop recording. Are there any questions?